Yes, any questions from your end? If no questions from your end, then how do you go about it? I cannot go through everything in 1.5 hours. What we need to do is probably focus more on things which are clinical. In your end of module, you would have got more questions which were from probably your areas which were more basic. Here, the questions will be more clinically oriented. So the topics which are mostly clinically oriented, if you look at it, I would say you would have to focus on things like the ECG. You would need to focus on things like your heart sounds, your pulse, your JVP, and you will be able to, should be able to focus more on the pathophysiology of edema. And of course, you will have a lot of questions from both your SLP and your practicals. So that the rubric now, most of the auspices come from the practical. So you need to shift your attention to these as well. Concentrate on scenarios which have things to do with myocardial infarction, heart failure, abnormal heart sounds. So one question, what are the, I don't really know, remember any of the questions that I made. Probably I will start with sharing a few slides and later we can try to see how things go. Okay, what are the causes? Everywhere you need to look at the heart sounds, differentiating the heart sounds. Then we ask you things like, what are murmurs? What is the cause of murmur? What is the pathophysiology of murmur? So anyone, what do you think is the pathophysiology of murmurs? How are murmurs produced? Now this class has no meaning if you come just to sit and listen to me. I'm not going to give you out any questions. So probably you are at a loss, and as well as me. Unless you respond, I don't even know whether you guys are around. And whoever organizes these classes, I don't know, it's absolutely a worthless behavior from either end. Anyone in the class? What is the cause of murmurs? What causes murmurs?
Murmurs that were within the flow.
Yeah, the answer we are looking for is either a normal flow through an abnormal valve or an abnormal flow through a normal valve. So if you take a case of anemia, the murmur is because the volume of blood is high. If you take a case of, say, any of these valve stenosis or regurgitation, that itself will cause a murmur because there is a abnormal flow, normal flow through an abnormal valve. So either the valve is abnormal or the flow is abnormal. That is what we are looking for. And it usually carries one question. Then you will need to differentiate between the different types of heart sounds. In that, focus on what causes it, what causes each of the sounds. First sound because of closure of. One of you quickly keep answering the questions so that we can move forward. First sound caused by
AV valve.
AV valve. Second heart sound closed by
Semilunar valve.
semilunar valves. Third heart sound caused by Usually if they say the S3, they'll say if the patient comes with a heart failure with S3, it usually indicates systolic heart failure. If a patient has S4, usually he has a diastolic heart failure. So the systolic heart failure, the problem is with the early rapid filling. Diastolic failure, the problem is with the late filling, late active filling, or the last active filling, which is also called atrial systole. So these are the type of questions which you are going to expect rather than the ones you are used to when you are talking in the, when you have your end of module exams. Okay. Then we ask you what are the characteristics of, not characteristics, we probably ask you the location, where do you look for the best third? Then we look for the ECG in coordination with the heart sounds. So the first heart sound coincides with your, on the ECG, what is the correlation between the ECG and the heart sound? The first heart sound coincides with R wave. The second heart sound coincides with the T wave, probably starting around 90 to 100 milliseconds after the beginning of the T wave. And the third heart sound is somewhere on your TP interval. And the fourth heart sound is just after your P wave between the PQ segment, the PR segment. So this is what you need to focus on. Of course, the characteristics, first sound is loud, it is low pitched. Second heart sound, short, sharp. Just remember SS, short, sharp, second down. And the third and fourth are barely heard. Why are they not heard? That is another question we ask. Why are the third and name two sounds, state the characteristics of two sounds which are not heard? They are usually not heard because they have a very low frequency, usually below 20, which is below your auditory frequencies. Then we ask you things like, what is physiological splitting? Explain physiological splitting. So what is the cause of the physiological splitting? Or what is physiological splitting? Expiration, you will hear a single heart sound. Inspiration, you will hear the second sound is split into the aortic and pulmonary component. The reason for that is during inspiration, there is an increase in the venous return to the heart, and there is an increase in the blood flow to the lungs. One is the air enters into the lungs. This stretches the blood vessels of the lungs as well. So this causes venous engorgement in the lungs. So the amount of venous return to the left atrium is reduced. Plus the right ventricle output is increased. So both these things, they push the septum towards the left. So what it does is it will reduce the pulse amplitude and it will decrease the volume in the left ventricle. So the pulse will be not felt and you will still hear the heart sounds. So these explains two things. One is it explains a phenomenon called pulsus paradoxus, which we again ask you to explain. So pulsus paradoxus and physiological splitting, the reasons are similar. Inspiration causes increased blood flow to the right side of the heart and reduces the blood flow to the left side of the heart. So the left ventricular output is decreased, right ventricular output is increased. So it takes more time for the blood to leave the right ventricle, so the pulmonary valve closes later. This causes the pulmonary valve to close later than the aortic. So this causes the physiological splitting. And when you talk about pulsus paradoxus, normally during inspiration, the blood pressure will fall by, the systolic pressure falls by anywhere between 5 and 10. If it goes beyond this, if the fall is more than 10 millimeters of mercury, you call it pulsus paradoxus. What is the paradox? The paradox is you can hear the heart sounds when you auscultate, but you cannot feel the pulse. So that is called a pulsus paradoxus. And this is usually seen in conditions where there is a increased reduction in the blood flow to the left side. This occurs when either the heart is pressed upon in cases of pericardial tamponade or in cases of COPD, especially in status asthmaticus, when the air is trapped in the lungs. So when the lung is volume is increased, the blood flow to the lung also increases. So more blood is pooled in the lung. So the venous return to the left side of the heart is decreased. Same thing happens when you have a superior vena cava obstruction, either because of a thrombosis. So again, the blood flow will reduce. So all these conditions, usually there is an exaggeration of a normal phenomena where the systolic blood pressure falls between 5 to 10. If it falls more than 10, you call it a pulsus paradoxus. And you should know one or two causes where this increases. Then about the JVP, you should know all the three waves, the A wave, the C wave, the P wave, what causes them, and what conditions where the CVP is increased or the CVP is reduced. So that is where your focus in this case should be there. Okay. Then what else here? Yeah, sometimes you will get the clinical scenario itself will have the heart rate. And the heart rate is given in the scenario 110. And you are asked to comment what happens to the heart rate. What happens to comment on the heart rate. So all you have to say is if a person has got tachycardia. Now suppose the patient comes in with a heart rate of 225. So again, the person has got tachycardia. And we are asking you what will happen to the cardiac output when the heart rate is 3 times normal at 225. Anybody? When the heart rate is 225, what will be the changes you will expect in your heart rate, in your cardiac output?
Reduce.
Yeah. And the reason for that is?
Shorten
Explain.
total cardiac cycle.
Yeah. So what it will do is because of the decrease in the duration of the cardiac cycle, the duration of diastole will decrease remarkably. So the ventricles cannot fill or the end diastolic volume will decrease. So when the end diastolic volume decreases, the stroke volume will also reduce because this is directly dependent on the Frank-Starling's mechanism, which states that more is the stretch on the myocardium, more is the force with which it will contract. So if the myocardium, the left ventricle is not filled, it will not empty. So the volume will come down, stroke volume will come down. So when the stroke volume comes down, definitely your cardiac output will also come down. So that is another question which you can normally ask. So the list of questions I've given you already, mechanism of production of heart sounds. You differentiate between the heart sounds based on their characteristics. Then you have to explain things like physiological splitting and pulsus paradoxus, and differentiate between the waves of the JVP and the different segments of the pulse. And of course, your features of the relationship between the ECG and your heart sounds. So this is all that you need from this important section. ECG, we ask you to maybe identify segments. What is the importance? So you need to remember in ECG, you have to remember that the segments you look for elevation or depression. In case of intervals, you have to look for duration. So most important interval for you is the PR interval. So if this interval is more than 200 milliseconds or 0.2 seconds, it means the person has got first degree heart rate. So in intervals, the wave is included. In segments, the waves are not included. So that is your important. Then sometimes somebody may ask you what are the changes which are seen in cases of, what are the ECG changes which are seen in cases of myocardial infarction? That is one question which is usually asked. So depending on the infarct, is it a STEMI or an STMI? So if it is a ST elevation MI, you will definitely find ST elevations of more than 2 millimeters in two contiguous leads. That is what your answer should be. And this elevation is usually of the convex type. This will be followed by T inversions, and the ST will slowly come down. And once the infarct is established, you will have a pathological Q wave, which is deeper than 1 millimeter and wider than 1 millimeter. So that is a pathological Q wave. Development of a pathological Q wave means the heart muscle is already infarcted. And this Q wave will remain on the ECG throughout life. It will not going to change. So if it is in the inferior leads, it means the person has got an inferior heart attack. So inferior leads are which are looking at the heart from below, which is your lead 2, 3, and AVF. Similarly, if you look at the anterior leads, V1, V2, it means there is the infarct of the probably of the right ventricle. 3, 4 is probably septal. 4, 5, 6 usually are your lateral leads, especially your 5, 6. So these are your lateral leads. So based on this, all the leads can be involved, which is called a global MI, or you can have a specific segment where there's a MI. So that is what you need to remember from your ECG: waves, intervals. Of course, the normal QR, PQR, ST, all those you have to remember. Coming to the edema part, important thing to remember there would be the Starling's forces. The Starling's forces, so everywhere there should be a balance between absorption and exudation or secretions. So if you look at the place, any situation where the pressures which are favoring filtration, that will lead to a escape of the fluid into the interstitium, which will cause edema. If this edema is throughout the body, you call it anasarca. So causes, if you ask you what is the cause of say edema in venous congestion, say the person has got congestive heart failure, what is the cause of edema? Anyone? Explain the pathophysiology of edema in heart failure. What will be your answer? Congestive heart failure leads to venous congestion. So when there's venous congestion, there is an increase in the venous hydrostatic pressure. So when the hydrostatic pressure increases, it favors filtration. So the fluid will escape from the veins into the interstitium. This causes the edema. What is the cause of edema in cases of, say, renal disease? A person has got glomerulonephritis. What is the cause of edema here? How will you explain this?
Water retention.
Glomerulonephritis. Anything else you can think of?
Pumping.
Anything else you can think of other than the water retention? What is the most important thing which retains fluid in the blood vessels?
Loss of protein in the urine, causing decrease the albumin.
Yes. So basically, the question is, what holds the fluid back in the blood vessels? The other way to ask you is, what is the most important contributor to plasma colloid oncotic pressure?
Protein.
Albumin. Plasma proteins contribute to the oncotic pressure. So the oncotic pressure, the albumin is also hygroscopic. It will bind the water and keep it in the blood vessels. So anywhere there is a loss of plasma proteins, either because of a kidney disease where there's a loss of protein, which can occur in conditions like, what are the conditions in which you can lose proteins in the urine?
Glomerulonephritis.
Glomerulonephritis. What else? What are the conditions in which protein is lost in the urine?
Diarrhea.
What are the causes of proteinuria? That's my simple question.
Nephrotic syndrome.
Yeah, nephrotic syndrome, nephritic syndrome. Anything else? Simple things. Any chronic inflammations? Low pressures, extreme temperatures. These are common physiological causes. So dehydration. These also will lead to protein loss. So anywhere there's a protein loss or there's a problem with the production of protein. So if you have a liver disease, what will be your answer? A person has got cirrhosis of the liver and he has got generalized anasarca. What is the cause of? Explain the pathophysiology of the anasarca. What will be your answer?
Is albumin synthesis.
Yeah, albumin is produced by the, all plasma proteins are produced by the liver. So in case of cirrhosis, the liver is unable to produce your plasma proteins. So there's low plasma protein, which will lead to low oncotic pressure. So again, the fluid will escape into the interstitium. So every different cause, you should be able to explain the pathophysiology of edema based on the cause. So it could be heart failure, could be renal failure, could be your hepatic failure. And invariably, problem with one will always lead to the problem of the other. So now we have a cardiorenal syndrome, you have a cardiohepatic syndrome, you have a cardiorenohepatic syndrome, where all three are involved. So end-stage disease, everything will be involved. Because if one fails, invariably the other will also fail in due course of time. Okay, sometimes maybe you can get, I'm not sure, but I don't even remember the questions. Anything else you can think of in cardiovascular system? Heart failure, edema, ECG, pulse. Anything else you can think of? I think more or less this is what we need to remember for. Yes, cardiac cycle, of course, there'll be a lot of questions. The pressure volume changes in the cardiac cycle, because this is this can be a question in any of your exams, either during systole or diastole. We don't know. Explain the pressure volume, state the phases of cardiac cycle, and describe the volume changes during systole, or state the phases of the cardiac cycle during ventricular diastole and state the volume changes, or it could be the pressure changes. Usually events will be referring to your ventricles. So unless otherwise mentioned, just mention your changes in the ventricular volume or pressure. You can focus on the coronary circulation as well. Why does coronary circulation, the blood flow is mostly during diastole and not during systole? The reason for that is during systole, you have your intramyocardial vessels which are compressed. So they can be, the coronary flow is there is your subendocardial arterial plexus. So most of the blood flow to the heart occurs during your phase of diastole, especially in your left coronary arteries. The reason for that is the intramyocardial blood vessels are squeezed during systole, so the blood flow will be decreased and the blood will flow mostly from the redistribution of fluid from the subendocardial plexus to the subepicardial plexus. And opposite of this occurs during the diastole. During diastole, blood flows from epicardial plexus to your subendocardial plexus. So that is something, and of course, we ask you what are the causes, what are the regulation of coronary blood flow. So you have to talk about the chemical regulation. When the activity of the heart increases, it produces a lot of vasodilators. Vasodilators include decrease in the PO2, increase in the PCO2, decrease in the ATP, increase in the ADP, AMP, adenosine, and lactate, hydrogen, potassium. All these are vasodilators. The second theory is the neural theory, where direct stimulation of the heart, when you stimulate alpha receptors, causes increase in the heart rate. So this will also cause increase in the cardiac output, which increases the work of the heart. So again, the neural regulation also works directly through your chemical regulation ultimately. So both these factors you have to make mention of. Neural factors and chemical factors regulating blood flow, and why is blood flow occurring only during diastole. So from the heart, I think probably these are important questions. Any questions from your end? Now that you have spoken from quite some time. Any questions from you, from your end? Nope. Then the next move is towards anyone? Any questions from the CVS? These are the important things I could remember. If there's something you want to discuss, you let me know. From respiration, probably what are the things which are important for you? What do you think? For me, your spirometry is always important, where you have to remember all the volumes, the difference between volumes and capacities. Then what are the volumes which you cannot measure? So based on the volume which you cannot measure, what is the other method to measure these volumes? And lastly, the normal values of these volumes and capacities. So that figure of the spirogram, you have to remember whether you like it or not, along with their values. Then based on those readings, you can differentiate the lung conditions into two broad categories. What are they? What are the two broad categories of respiratory disorders which you can think, which you are aware or should be aware of?
Restrictive and obstructive.
Yes, so you need to differentiate between the two using your spirometry. So you have to talk about the ratio of your FEV1 by your vital capacity. So normally these ratios should be above 80. If they fall below this, it is probably a obstructive disorder. If it is normal or above this, probably it is a restrictive disorder. So or just remember one simple fundamental I will tell you. In obstructive disorders, all volumes will increase. And in case of restrictive disorder, all volumes will decrease. So that is one easy way to remember and differentiate. Once you've got that, you can work the ratio backwards. Okay. So the spirometry is important. Then we are one SLP we covered there somewhere on oxygen and hypoxia. So you should know conditions, the type of hypoxia, cyanosis, definitions, cyanosis, that differentiate between central and peripheral cyanosis. Then oxygen toxicity. What do you mean by oxygen toxicity? And signs and symptoms of hypoxia. And of course, the types of hypoxia. Where is oxygen helpful? Where oxygen is not helpful. So this is the important clinical aspects of from the SLP. So you should be able to define cyanosis. You should be able to give us causes. You should be able to differentiate between central and peripheral cyanosis and types of hypoxia and their causes and conditions where oxygen therapy will help and conditions where oxygen therapy will not help. So if you have a histotoxic type of anemia, it will definitely not help because there's a problem with your enzymes, which you cannot correct. Say in cyanide poisoning, any poisoning with sodium azide. So that is all I can think of right now in the SLP. Then you should know things like, the regulation of respiration. In this, you should know what is neural regulation, what is chemical regulation. So what is the most important stimulant of central chemoreceptors? You should know the difference between the chemoreceptors and baroreceptors. Where are the central chemoreceptors? Where are the peripheral chemoreceptors? Where are the peripheral chemoreceptors? Everybody is silent. Where are the peripheral chemoreceptors?
Aortic and carotid bodies.
Yes, aortic and carotid bodies. And what do they best respond to?
Hydrogen ion.
Aortic and carotid bodies best respond to
Oxygen and hydrogen ion.
oxygen. Yes, they respond best to hypoxia. Whereas central chemoreceptors, they respond best to
Hypercapnia. Carbon dioxide.
carbon dioxide. Now, what is the problem with transport? You should know each of these centers which are there in your first of all, I told you, know the differences between your chemoreceptors and central and peripheral. The second thing you need to know is the difference between the baroreceptors and chemoreceptors in where do these help in the cardiovascular system? Where is the role of chemoreceptors and baroreceptors?
Pressure.
In a bit louder.
Is
What
it
is
blood
the
pressure?
yes in the neural regulation of blood pressure? So you will have a short-term regulation and a long-term regulation of blood pressure. Short-term regulation of blood pressure, if the pressures are between 70 to 170, these are regulated by baroreceptors. If it is below 40, 40 to 70, usually they are regulated by chemoreceptors. And when it falls below 40, it is regulated by what is called the CNS ischemic response. Have you heard this term?
Yes.
So you should be aware of these. Then what is the role of each of these centers? So the central chemoreceptors respond best not to carbon dioxide. What do they respond best to? Central chemoreceptors respond best to dash, fill in the blanks.
Carbon dioxide.
Come again?
Carbon dioxide.
No, I told you not to carbon dioxide.
Hydrogen ion.
Hydrogen ions. They respond best to hydrogen ions. But the problem is you cannot transport the hydrogen ions across the CSF. So you need to have this hydrogen ion is basically formed after the carbon dioxide is combined with water, then goes in as the carbonic acid, then dissociates and forms your hydrogen ion and your bicarbonate ion. So this hydrogen ion can stimulate your central chemoreceptors. What else you need here? There you should, again, some type of abnormal breathings like your apneustic breathing. What are the causes of apneustic breathing? What are the causes of, say, Kussmaul's respiration? Person comes with diabetes. What will be the type of respiration? A person has got opioid toxicity. What will be the type of respiration? So at least you should know what have you heard these terms? Chain strokes breathing.
Yes.
So what is this chain strokes breathing? The tidal volume increases and decreases. So what is called the waxing and waning of tidal volume. And in between, you will have period of apnea. This is very typically seen in cases of hypoxia and any cause of drug overload, especially with your opioids. What is Kussmaul's respiration? Increase in the rate and depth of respiration. So the tidal volume increases, the respiratory rate increases. So deep inspirations and expirations. This is typical of Kussmaul's respiration, most commonly seen in diabetic ketoacidosis. What is apneustic breathing? This is prolonged. The cutoff switch is not there. Yes. So there's a period of apnea. Long period of apnea. What does this show? Either the pneumotactic center is not working, or you have got the vagus are missing. Is any damage to the vagus? When you don't have the vagal input, what does the vagus do? The moment the lungs are stretched, inspiration is to its maximum. Then these vagal inputs, the lungs are stretched. This is detected by the vagus. These impulses are carried to the CNS, and this will put an end to the action of the pneumotactic center. So if this is not there, any lesion of the pneumotactic center, what will happen? The apneutic center will go unchecked. So you will have prolonged inspiration. So the apneistic center, basically, what is the role of the apneistic center?
Prolonged inspiration.
It inhibits the apneistic center. Pneumotactic center will inhibit the apneistic center. So if the apneistic center is not inhibited, the inspiration will be prolonged. What is called apneusis. So at least this unusual type of breathings, the centers, what is the pneumotactic center, what is the apneistic center, and the two dorsal and ventral. Broadly, I just simply remember dive. Dorsal group, mostly inspiratory. Ventral group, mostly expiratory. What else? What else do we need here? The other thing I think probably you should know about is the ventilation perfusion ratios. Ventilation perfusion ratios, which part of the lung gets maximum ventilation? Simple questions, no? Which portion of, yeah?
Apex.
Are you sure?
Base.
Are you sure? Anyone else? Which part of the lung gets best ventilation?
Lower loop.
Which part of the best lung gets best perfusion? Why, you have read all these, right?
Base of the
Okay.
heart. Base of the lungs.
Yes. So both ventilation and perfusion are always higher at the bases. Are you clear about this? Then let me wait. Let me try to help you with some pictures. This is, I think this part is not clear to you guys. Let me help you. Okay. Share. Do you see this slide of mine? Do you see a ventilation perfusion ratio slide?
Yes.
Okay. So what does it show you here? Wait, pen. So you are going from the base towards the apex, right? And this is showing you the blood flow and ventilation. So what do you see? Where is the ventilation more? It's at the base. Where is the blood flow more? It's at the base. So the base has got higher blood flow, which is your perfusion, and it has got a higher ventilation. But as you go from the base towards the apex, what is happening? The blood flow is dropping and the ventilation is dropping. But the blood flow falls more than the ventilation. Have you followed this? So when you look at the ratio of ventilation to perfusion, what is happening here? Here the ventilation is higher, perfusion is higher. Here, what is happening? The ventilation is higher, the perfusion is lower. So if you look at the ventilation perfusion ratio, the ventilation perfusion ratio is higher at the apex, but lower at the base. Have you followed this?
Yeah.
But the blood flow
Yes.
and ventilation are both higher at the bases. Have you understood this? We ask you this, the ventilation perfusion ratio and how it affects, or how this ratio changes. So suppose your ventilation is 0. You got this? Your ventilation is here is 0. What will be the ventilation perfusion ratio?
Zero.
Then at your level, you should know something about what is the dead space and what is the other thing? Dead space and
Physiological shunt.
physiological shunt. Yes. So what is the dead space?
Area with no perfusion.
Yes. In a dead space, what you are having is there is a ventilation is present, but there is no perfusion. So you have an anatomical dead space which extends from your nose right up to your terminal bronchus. So there is no gas exchange in these areas. And the volume of this space is? What is the normal volume of the anatomical dead space? What is the normal volume, anatomical volume of the anatomical dead space?
150 ml.
150. So sometimes they will ask you, tidal volume is 500. Dead space volume is 150. What is your pulmonary ventilation? And given the respiratory rate is 12 or 10. Make it easy, make it 10. What will be your alveolar ventilation? So tidal volume minus anatomical dead space times respiratory rate. So 350 minus 500 minus 150, it will be 350. And if I say respiratory rate is 10, that will make it 350 by into 10, which will be around 3.5 liters. So that is how you calculate your anatomical dead space. What else? Yeah, if you have a case of say sinus, what do you call that? Infiltrative lung disorders, coal miners, whatever. So in that case, there will be some questions on lung defense mechanisms. So what happens in different types of when the particle size changes? So if you have a particle which is too big, that is usually will be filtered by the nose itself. So any particle which is more than say 10 microns. That will be filtered in your nasal passages. Anywhere between 2 to 10 microns. This will usually be cleared by anything between 2 to 10 microns. This will be cleared by
Mucociliary escalator.
mucociliary escalator. That is why you need to know the three important constituents of the mucociliary escalator, which is your gel, your sol, and your cilia. So if any of this is wrong, you cannot have the mucociliary escalator. Then anything below this up to your 0.2 microns, 2 microns to 0.2 microns. These are usually cleared by
Dust cells.
dust cells, or these are also called your pulmonary alveolar macrophages or dust cells. And if they are below 2, then they are usually will be diffusing out and they will cause inflammation of the lung and cause your infiltrative lung disorders. So you need to know about these, the mechanism of, a lot of times we ask you, there's a smoker. A smoker comes to you, how does it affect your lung defense? So you have to talk about the mucociliary escalator. Then sometimes what is its effect on the goblet cells? So the number of goblet cells will increase and they are found further late into the respiratory tract. So those are things we need to remember. Sometimes I think cystic fibrosis, usually we don't ask you simply because we don't get any cases of cystic fibrosis here. What else? The Bohr's effect, Haldane's effect. That is something somewhere along the line you may be asked about those. Explain Bohr's effect, explain Haldane's effect, either in RESPI or. So what are the things which move the curve to the right, to the left? Now make sure you follow what is being asked. If they ask you what shifts the oxygen dissociation curve to the right, see whether it is mentioned there right or left. Because sometimes it will be right, sometimes it will be left. So make sure you follow the question. You just cannot write CO2, temperature, your 2,3-DPG. No. Carbon dioxide. No. Simply because you have to mention increase in. So technically, anytime the oxygen dissociation curve moves to the right, just remember there's an increase in either the hydrogen concentration or the carbon dioxide or your temperature or your 2,3-DPG. If it is to the left, all this have to reduce. So you have to mention the increase or decrease of these parameters. Don't just write carbon dioxide temperature. Then you might not get your full marks. What else? Anything else you can think of here? Yeah, oxygen carriage. Usually we'll ask you that oxygen dissociation curve, Haldane's curve. If you are unlucky, you can get the gas loss because there's usually a EMQ. What is that? Yeah, EMQs. So there we have left with very few choices for EMQs in respiratory. What else? I think more or less, what else left here? Pulmonary circulation, I don't know what are the sort of questions in clinical. I don't really know. But if you talk about pulmonary circulation, you should know the 3 zones of blood flow. And you should know which phases of the cardiac cycle these zones will, or how are these zones separated out. The 2 types of blood flow, high flow with low pressure, or high pressure and low flow. So those 2 type of circulations and the zones of blood flow. More important probably for me would be your zones of blood flow. So what will happen at the zones which are, say, above 10 centimeters? Then somewhere which are structures which are below the 10 centimeters from the midline of the heart. So the zone 1 is the zone which is not normally seen in in a normal lung. It can only be seen when there is some pathological disorder. So in this zone, there's practically no blood flow because the alveolar pressure is more than the pressure of the pulmonary artery, and it is more than the pressure in the pulmonary vein. So there's almost zero blood flow. This is always pathological. It never occurs in a normal lung. So anywhere where the alveolar pressure increases, say you are using a positive airway pressure, using your mechanical ventilator, or your blood flow is very low because of, say, some severe hemorrhage. So these are the 2 conditions where the lung apex might not get blood flow, or certain areas of the lung may be starved of oxygen. So these are areas, basically the zone 0, where there is no blood flow throughout the cardiac cycle. The zone 2, you will have blood flow during systole. So anywhere which is above 10 centimeters of the heart in a normal lung, it will get blood flow during systole. Whereas areas which are below 10 centimeters from the midline of the heart, these will get blood flow both during systole as well as during diastole. So this is the 3 zones of blood flow which sometimes you may be getting. What else here? If there's a question on pleural effusion, probably all that you can be asked is what is the safety factor? That is all I can think of for you here. And transport of gases, of course, you will need to know your values, normal values for arterial end and venous end at the arterial in your pulmonary capillaries, in your systemic capillaries. So how oxygen is picked up, how it is transported, why it falls as it comes from the left atrium into your from the pulmonary capillaries to the left atrium. Why does the level falls? CO2 level fall here. Why does it fall by the time it reaches your lungs? I'm sorry, your tissues. Those are the sort of questions we will ask you. I'm tired now. So unless you have questions, I cannot go on continuing with this. Any questions from your end? Anything you want to sort out? See, the whole exercise will be helpful if you come prepared with your questions. If you're hesitant to ask them, probably you could type a few questions if you're so willing. Then in case you don't have any questions, I think we will stop here. I cannot go on speaking to walls. Shall we stop here?
Yes.
Okay. And